So what we're looking at now is the bicipital restraint mechanism, essentially. Okay, we can get some information as far as the actual biceps tendon with this as well, but we're really looking at that fascial tube that is going to run through. Okay, so we're looking at pec major, we're looking at the floor being the lats, we're looking at teres major. Make sense? Okay. There's a couple different ways to do this. We'll talk you through both of them here. First thing I will do is I'll bring her into this position and I'll just ask her, just resist me right here. And in this situation, she's pretty strong, so I think she's doing fine. We'd look for reproduction of pain. Reproduction of pain with that one, not as good as we're going to get as far as actual biceps tendonitis tests or tenosynovitis tests. There's been some other ones that I've seen that come way out here and try and use a particular vector. I have never had good success with that. Even when I go in and I palpate the tendon and the tendon is tender, it still doesn't reproduce it. So I stick with this one because this one I still get pretty consistent result with. So if we get a production of pain with that, what I want to see is if it's the actual tendon or if it's going to be part of that restraining mechanism, so forcing that biceps tendon into that. Okay, so to do that, what we're going to do is we're going to bring her into kind of these positions here in internal rotation to start. And what we're going to do is we're going to stress the mechanism posterior laterally here. Okay, so we're going to go, again, just along the joint line. Okay. As I push down like that, and she's getting a little bit of body tilt too. As we go down like that, clunk. Yeah. So, no, but that doesn't mean much really. Okay. Yeah, so, well, she's actually pretty strong, but she did get a little click there. So, what we're looking at with internal rotation there, let me get this right, is we're looking at stressing the lateral portion of the groove. Did I say that right? Yes. Okay, good. So essentially the stress isn't necessarily on the tension on that particular musculature, it's where the biceps tendon presses into that. Okay? So the pressure isn't me trying to stress the pec major at that point. It's with me trying to push the biceps tendon into the pec major. Okay? She gets a little click, so I might think at that point that we're actually getting that biceps tendon to sublux slightly in that direction, so that pec major tendon may have something going on with that. Okay? If we're looking at the medial portion of the groove, we're going to put her in basically the same position, but we're going to externally rotate now. Okay, and then we're going to go right along that same joint line, and that one is just fine. Nothing going on there. Okay, so that's the first way that we can go about that, and that's what's written up in the notes, and this is the way that Earl Pettman has taught it for years and such. The last line of his paperwork says, "Digital palpation is confirmatory." So when we started thinking about that, the question became, why don't you just go back directly to the lateral portion of the groove and palpate the tendon itself to see if it's become sore? And that's what I do now, is I'll just go directly to that particular portion of the bicipital groove, and I'll look for the particular sore spot. And the reason I started doing that again, I wasn't getting consistent results with my palpation and with the stress. For whatever reason, whether it was my technique in particular, whether it was the position of the shoulder, or whether it was actually the pressure coming from underneath as opposed to the pressure coming from above. So coming from within the groove versus coming from outside the groove. Whatever the consistency with it was, I wasn't getting good results. So if you're having a hard time with that, I would recommend just going in and finding that groove and going through the palpatory motions there. Okay? And if you really need to confirm, resist me here, resist me here for the two different heads of the pec, and then you can go in and do different things for the lats and for the teres as well. I actually don't know the one with the teres at the top of my head, but we can figure that out if somebody's curious. So That's the bicipital mechanism there. If we're looking at the actual intracapsular component of the biceps, as far as that being the pain producer, it's not in the groove. What we actually have to do is we need to come, basically if you're looking about halfway in between the edge of the acromion and the coracoid, you'll get right onto that. And this one I'll just do direct palpation with, and it should be pretty round. It'll feel like a pencil instead of something nice and flat. Biceps should flatten out as it comes over the top of that, over the top of the humeral head there, so it stays low profile, right? So it's not prone to impingement. When we start to talk about facilitatory problems and the way it can affect scapular positioning, it will affect how that bicep tendon, whether or not it lays flat or whether it buckles and becomes more prominent, or when it starts to swell and becomes more prominent in that space as well. And it kind of becomes a self-perpetuating loop at that point.
So that's that superior glenoid tubercle that we palpated. Okay, so we palpated all these structures that Eric's talking about just a little bit ago, every bit of them.
Okay?
And then, can I do the
Sure.
last one on that? Are you done with this, the
Yeah, go
bicep
ahead.
tendon?
Yeah, go ahead.
Okay, so the one, and I like this, this I learned from Cliff, it's in your notes, it's lay on your up side here. So, looking at the long head as an anterior restraint, okay, so now it's outside the capsule, but it's part of the restraint, and so sometimes the pain's coming because we've lost the capsule or the ligaments and we're dinging that tendon. And so we just want to palpate. This, Cliff designed it as a slap test, and I actually still like it, but again, no evidence for it, so this is funny. Okay, come here. Okay, this is actually, I don't know what else we've seen, and this would go right with what Eric found in his click. So I'm going to stabilize the clavicle and the scapula. Now watch as I go into extension. See that bump? Okay, now as we come in here, now what I'm going to do right there, that shouldn't actually do that. See that? That's the humeral head shearing. Okay, so something has changed, and now the biceps is going to be right there. And I'm going to just go straight up and stress test so the biceps is nice and stable, and we can externally rotate, and there it is right there. And we're catching the medial side. It was probably medial side right at where the slap inserts, the tendon inserts. And if she's comfortable, I'm going to internally rotate, and we're catching the lateral side. So now, here I'm going to do it one more time so you can see the laxity. Okay, that's abnormal. It's either abnormal in the superior capsule or a tight posterior capsule that's driving the humeral head forward, or we have stability issues. So just when you see that, you know that already. There's the bicep and the groove. Should hold that nice and tight. That actually feels like a capsular infill, so the capsule feels okay, so it might be the posterior capsule. But as soon as I go into external rotation, look right here. See that? See that give right there? Okay. Now, and then internal rotation, nice and tight. Now that is actually not, if that was the only sign, Jen doesn't have a painful shoulder, we would consider that maybe a type 1 or below slap. And like 80% of you have slaps, just because it's breaking down a little bit. So outside of that, this is normal. If that was only, so that's probably right where he hit that clunk as well. And you hit it in internal rotation?
Yes.
Okay. So he had her back here, so he's testing right there and pushing back. So it's the same position. So that's very suspicious that right there. There's just a little give in her system. Nothing bad, Jim. Okay, so you have, we're testing the bicep tendon. We are testing it with testing the fascial tube by going posterior lateral when the arm is externally rotated and when the arm is internally rotated. We're testing it by palpation. In all the palpation through those tendons that we already have done, we're testing it coming up as it crosses and it's horizontal into the superior trabecular groove, and it should be flat. And we're putting them on their side, and we're testing it as an anterior restraint with internal and external rotation. Okay?
One more thing, because we do that kind of supine speeds test when we do this first. If you want a dead giveaway, that the humeral head is not centered well, that will be weak. If it's not weak, if it's weak and not painful, essentially, they won't be able to hold you because it's not centered well enough for that to produce a good contraction of that.